The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Next, let's go to internal medicine. 45 female was rushed to the ER because of sudden left-sided weakness more prominent on the upper extremities. Localized lesion. The correct answer is right MCA. Because as you know, sa left-sided weakness daw siya, di ba? So it's kung may left-sided weakness dahil nagdedecassate ang motor fibers sa may medulla, sa may part sa may near the medulla, nagdedecassate yung motor fibers. So yung pag may left-sided weakness, the part of the brain that controls it is the right side. So kaya right dapat, no? And so the question here, so kung right ang sagot, why is it not letter C? Okay, alisin na natin tong B and D. Bakit hindi C? Okay, so the correct answer that kung bakit hindi right ACA is itong homunculus na to. Okay. So, bakit MCA at hindi ACA? So, okay. Take note, ang sabi dito, left-sided weakness, more prominent on the upper extremities. Okay. So, paano ba pag ACA? Tingnan muna natin tong illustration na to from first aid. Ang sabi dito, ang sinusupply ng ACA is itong light yellow-green. So, ito yung sinusupply ng ACA. Ang sinusupply ni MCA is itong green na to, which is ito. And ang sinusupply ng PCA is itong purple, which is ito, no? Okay. So, yung patient natin is may weakness na more prominent on the upper extremities. Sino ba yung nagko-control ng upper extremities? It's the MCA. As you can see, dito sa motor homunculus na to, ito yung representation ng arm. Ito yung representation ng upper extremity. And ang nagko-control sa kanya is itong MCA, itong green na to. Which is why, sa patients na may MCA infarct, is meron din silang aphasia. Kasi nga, nagko-control din dito sa mouth and sa eyes, sa face, is yung MCA. Okay. Kaya dito sa patient natin na to, more prominent on the upper extremities, left-sided weakness, upper extremities, so it's most likely the MCA. Now, what if it's and that is the reason kung bakit ang patient na may weaknesses more prominent sa left upper extremity is anterior cerebral artery, because according dito sa motor homunculus na to, ang nagko-control ng legs is itong yellow-green na to, which is the ACA. Okay, so that is the reason why. So seeing it from using this illustration or this figure, if you see it from with the help of this figure, it makes it easier for you to remember na kung bakit pag may ACA infarct is weaker yung left extremity. Okay? And if it's pag may aphasia and may weakness of the upper extremity, ay MCA yung may infarct. Okay? Okay, number 2, Ellie was worried because her 79-year-old grandmother has been having auditory hallucinations for more than a year now. Gibberish. Okay. The correct answer is letter D, schizophrenia, on the basis of auditory hallucinations and delusions and disorganized behavior. Why not the others? Kasi ang sabi dito, yung grandmother niya has been having it for more than a year now. Okay? Kasi ang schizophrenic form lasts for only 6 months. 1 to 6 months. Yung grandmother niya is for almost for a year na, okay? And then ang schizoaffective naman, schizo and then affective ay schizophrenia and mood disorders ang combination. Schizotypal personality disorder is a personality disorder na may na medyo kamukha ng schizophrenia. Okay? So, dito sa patient na to, dahil may auditory hallucinations siya, delusion, and disorganized behavior for more than a year now, most likely it's schizophrenia. Kasi wala naman sinabi dito na may mood disorder siya, So it's less likely though. Number 3, which of the following is true regarding different maneuvers and its effect on heart murmurs? The correct answer is letter C. MVP murmur increases during Valsalva. Okay, so there are a lot of valvular lesions that nag-increase yung murmur pag in-increase mo yung venous return, and ito yon, except for dalawa, HOCM and MVP, na nagdi-decrease yung murmur if you increase the venous return. Okay? So opposite yung kanyang effect, no, ng increasing the VR. And it's the same thing, and it's the other way around naman. Pag dinecrease mo yung VR, if you stand and if you do Valsalva, most of the murmurs will decrease in intensity while the HOCM and MVP will increase in intensity. So the reason why nagdi-decrease yung venous return if you stand, well, kasi pag nag-stand ka, nagpo-pull yung blood sa extremities, and if you do Valsalva, you increase there's increase in the positive intrathoracic pressure, so hindi maka-return yung venous blood from the IVC and the SVC. So pag hindi sila maka-return to the heart, there's decrease in venous return, and that increases the murmur of HOCM and MVP. Okay, so dalawa lang naman tong valvular lesions na to na opposite ang effect from the other valvular lesions na ito. Okay. When performing CPR, how often should you check for the pulse? The correct answer is letter D, every 5 cycles. Actually, kung wala yung 5 cycles, na mag-check ka for the pulse for every 5 cycles. Kung di nyo makita yon, it's every 2 minutes. Pulse check at interval of 2 minutes. Okay. And you should also remember yung other numbers, like high quality CPR is not more than 100, or there's a certain number of high quality CPRs, which is 100 to 120 compressions per minute. Okay, per minute. And the depth of compression, kailangan nyo rin tandaan na 2 to 2.4, allowing for chest recoil. Okay. Number 5, which of the following is false regarding asthma and COVID-19? The answer is vaccination is generally not recommended. That is false. Okay, kasi it is recommended, but the asthma should be controlled first. Okay, we should delay it if the patient is uncontrolled. So in this case, ito ang mali. Kasi recommended man talaga ang vaccination, pero the asthma of the patient should be controlled. So for example dito, vaccination should not be given during acute exacerbation. That is true, kasi dapat nga is i-delay mo siya if it's uncontrolled, no? Itong letter A, yung asthmatics do not have increased risk of COVID-19. So that is also that is true, no? They do not have increased risk of COVID-19. Doesn't mean na may asthma ka is increased ka ng COVID-19. And then letter D, asthmatics needing oral corticosteroids have increased COVID-19 related mortality. Kasi pag yung mga patients na that need oral corticosteroids, it means that they don't have their asthma controlled well enough, which means so aside from having increased mortality dahil nga uncontrolled lagi yung asthma nila, is nakakadagdag din yun sa pag-increase ng COVID-19 related na mortality. Kasi baseline pa lang, mataas na yung mortality rate nila. Kasi nga hindi controlled yung kanilang asthma. So, they have increased COVID-19 related mortality. Okay. Number 6, notice burning itchy lesions whenever she's not using her rubber gloves. The correct answer is irritant contact derm. So the difference between irritant and allergic contact derm is ang irritant is soon after exposure, within a few minutes. Ang allergic contact derm is delayed by a number of days. Okay? Kasi ang sabi dito is whenever she's not using her rubber gloves. So ang ina-assume natin doon is soon after exposure is meron siyang nakakaroon na siya ng lesions. So that's irritant contact derm. Okay. Number 7, the following meds can exacerbate MG except pyridostigmine. Why? Because pyridostigmine is the treatment for MG. It doesn't exacerbate MG. Okay. It is the treatment for it. So these are some of the drugs na pwedeng makapagpa-exacerbate ng MG. So I'll just leave it to you para i-memorize. Number 8. Okay. The answer here is letter B. Okay. Kasi ang sabi, may anemia daw yung patient. May anemia, okay? May anemia, tapos microcytic hypochromic, okay, and you suspected IDA, and you started iron replacement therapy. Okay, but soon she developed darkening of her ankles. So most likely this is a case of thalassemia with iron overload. Why? Um, okay, so because thalassemia is often misdiagnosed as IDA. Now, bakit ito na misdiagnose as IDA? Kasi hindi naman lahat ng microcytic hypochromic anemia, hindi lahat ay IDA. Kasi there are other differentials for patients with microcytic hypochromic anemia. For example, sa microcytic anemia, there are other conditions na pwede mag-present with that. Thalassemia, anemia of chronic disease, IDA, lead poisoning. So, ano mag-differentiate sa kanila? Ferritin. So, itong patient na to hindi na-requestan ng ferritin. So, inassume na lang na IDA. So, dito sa microcytic hypochromic anemia, if nagawan sana ito ng patient, if nagawan siya ng ferritin, and mababa yung ferritin, low iron source, IDA yun. Pero pag microcytic hypochromic anemia na normal or increased ang ferritin, it means maraming iron stores. It could be anemia of chronic disease or thalassemia. So, dito sa patient na to, dahil hindi siya dahil wala namang ferritin, wala namang benefit of the ferritin, and nag-develop siya ng darkening of her ankles, which means nagkaroon siya ng iron overload. So, it's most likely a case of thalassemia with iron overload. Okay? Kasi if it were IDA, hindi siya magde-develop ng iron overload, no? Number 9, okay, presents with polyuria, polydipsia, and sensorineural. It is caused by a defect in the sodium potassium chloride cotransporter and often mimics the effects of a loop diuretic. The correct answer is Bartter syndrome. So it could be confusing again. Yung Bartter, Liddle, Gittelman, Fanconi syndrome. So here is a very good mnemonic from first aid. Fanconi's bagels. Okay? And then, like yung kasi ang Fanconi syndrome, ang problem nito ay sa proximal tubule. Yung Bartter is sa loop of Henle. Kaya nga sagot kanina is Bartter syndrome kasi it mimics the effects of loop diuretics. So Bartter syndrome is problem niya is sa may loop of Henle, sodium potassium 2 chloride. Gittelman syndrome ang problem niya is sa distal tubule. Okay? Kaya ang effects niya is similar to using thiazide diuretics. And ang Liddle syndrome is sa collecting tubule naman ang problem. Okay? Kaya dito yung picture niya sa may collecting tubule, si Liddle syndrome. Alright. Okay. Your patient has an A1C of 9%. Okay. Screening for complications such as neuropathy and nephropathy should be done once a year. Okay. So, the way that you can remember this, I don't know if naturo na to sa inyo, the way that you can remember itong mga screening tests is yung annual, yung annual, yung word na annual is kukunin nyo yung consonants ng annual, NNL, yun yung consonants niya, di ba? Kasi annual ang pagtetest o ang pagsiscreen for neuropathy, nephropathy, and lipids. Okay? Kasi lipids is annual din. Okay? So, neuropathy, nephropathy, and lipids are annual. Okay? Kunin nyo lang yung consonants. How about yung eye exam and foot exam? So, imagine nyo, may dalawa kang mata, may dalawa kang paa. So, kumari paa yan. Okay? Imagine nyo na lang. Dalawang mata, dalawang paa, kasi 2 times a year or biannual, nagtetest or nagsiscreen for eye complications and foot complications. Okay? How about yung other tests? So for example, ito namang si blood pressure is quarterly and si A1C is quarterly din, no? 4 times a year. So paano ko na-memorize yan? Si A1C, di ba, ito yung arms ng tao, di ba? Tapos ito yung ulo, tapos ito yung paa. Okay? So saan ba nilalagay ang blood pressure cuff? Sa limb. Sa limb, sa arm, sa upper arm, sa arm, which is sa limb. Saan kinukuha ang dugo to test for HbA1c? Sa arm din, di ba? Kinukuha. So, ilan ba ang limbs mo? Or sa limb, kinukuha ang HbA1c. Ilan ba ang limbs mo? 4, di ba? Kasi 4 times a year, tinetest ang A1C. So, pilit na pilit, no? So, ang A1C is kinukuha sa arm, which is a limb, and ang blood pressure is, the cuff is nilalagay sa arm din, which is a limb, and you have 4 limbs. Kasi 4 times a year tinetest ang A1C, and 4 times a year din, or quarterly, siniscreen ang blood pressure sa patients na may diabetes. Okay? Which anti-hypoglycemic medication is associated with bladder cancer? The correct answer is pioglitazone. So, kailangan nyo ring i-memorize kung ano yung mga notable side effects of anti-DM medications. For example, ang biguanides is, or metformin is lactic acidosis, DPP-4 inhibitors, nasopharyngitis. Hindi lahat ng thiazolidinediones is nagpa-cause ng bladder cancer. Ang alam ko lang is pioglitazone. So, the way I remember this is, the way I remember this is, kung kilala nyo sa mga Catholics, kung kilala nyo si Padre Pio, yung saint, si Padre Pio, ini-imagine ko na si Padre Pio is namatay dahil sa bladder cancer. Okay, so I hope that it's not blasphemous. But that's the way I remember it. No, si Father, kasi lagi ko nadadaan yung Padre Pio na church, no, dun sa malapit sa amin. So si Padre Pio is namatay sa bladder cancer, so that's the way na remember ko siya. Others notable side effects of thiazolidinediones aside from bladder cancer is aside from fractures, kasi ito ay sa pioglitazone lang, aside from fractures is heart failure, okay, which is why hindi siya pwede sa mga patients na may heart failure. SGLT2 inhibitors, UTI, yung notable side effect naman because dahil nag-excrete sila ng glucose through the urine. Which of the following medication should you not prescribe if your patient is having acute gout attack? The correct answer is allopurinol. You should avoid urate-lowering drugs during an acute attack, gout, because they may exacerbate yung mga attacks. So the reason for that is during an acute gout attack, may mga crystals na nandun sa joints. No? So pag nabigay ka ng allopurinol or urate-lowering drug, the serum urate will rapidly decrease. So the serum urate will rapidly decrease. So what happens is, yung mga crystal deposits na nandun sa joint, no, dahil nag-decrease yung serum urate, nadi-disrupt yung parang chemical composition nila, yung chemical composition ng mga crystal deposits na nadi-disrupt. So what happens is, some of the crystals ay nagdi-disintegrate, and then some of the components of the crystal nasi-stimulate nila yung mga surrounding na local inflammatory cells, leading to more inflammation. So which is why allopurinol should not be given in patients during an acute gouty attack. Okay. There are several which autoantibody ng SLE is associated with heart problems? The correct answer is anti-Ro, not anti-La, anti-Ro. As you can see here, anti-Ro is associated with neonatal lupus with congenital heart block and also predisposes to subacute cutaneous lupus. But si anti-La, as you can see, wala siyang association with that. Okay, si anti-Ro lang. Next, Priscilla, enjoying a vacation on a cruise ship. After her cruise, nagkaroon siya ng cough, fever, and dyspnea. The correct answer is Legionella. Very typical na question stem for Legionella yung nanggaling sa cruise ship. Okay. Number 15. What is the most likely etiology ng dry cough, dyspnea, and hypoxia in a patient with a CD4 of less than 200? The correct answer is pneumocystis pneumonia. Why? Okay. Now, why not Mycobacterium? Kasi Mycobacterium avium complex or MAC, it only appears in patients with HIV pag ang CD4 is less than 50. Yung kanya 200 pa lang. So it's which is why pneumocystis. You don't have to have a CD4 of 200 in order to be susceptible with COVID-19 and mycoplasma, which is why hindi sila yung answer. Okay. Number 16. Patient na may Graves' disease, binigyan ng methimazole. How often should you repeat the FT4? Kasi di ba sabi natin, pag Graves' disease, ang minomonitor nyo is FT4. Pag hypothyroidism, or for example, Hashimoto's na hypothyroidism, ang ginagamit yung pang monitor is TSH. And in patients na binigyan ng methimazole, you would repeat ang kanyang FT4 every 4 to 6 weeks. Sa hypothyroidism, pag nabigay ka ng levothyroxine, you will check the TSH after 2 months or 8 weeks. Okay? Dito, 4 to 6 weeks. Hyperthyroidism Graves, hypothyroidism o Hashimoto, 2 months. Ang pag-check ng TSH sa hypothyroidism. Now, iba ang 4 to 6 weeks after starting treatment sa pag-follow up sa patient na may subclinical hyperthyroidism, which is 6 to 12 weeks. As you can see here, follow up in 6 to 12 weeks. Pag subclinical hyperthyroidism, okay, meaning subclinical hyperthyroidism, meaning normal ang T4. Low TSH, normal T4 is subclinical hyperthyroidism, follow up in 6 to 12 weeks. Iba itong patient na to na Graves' disease talaga, primary hyperthyroidism talaga, na binigyan mo ng methimazole, i-monitor mo siya after 4 to 6 weeks by getting serum FT4. Number 17, who among the following will you send for a coronary angiogram? So, the correct answer is letter C, by virtue of the fact na siya ay policeman. Okay? So, why not yung A? Kasi celebrity singer siya. Wala naman dito sa group wala naman dito yung population of singers na sila dapat ay isend for coronary angiogram. How about this one? 32 female about to undergo open heart surgery. So, hindi mo rin kailangan yan kasi there's an age cut-off for patients na kailangan mo isend for coronary angiogram, and that's 45 for males and more than 55 for females. Okay? And paano naman to? Who wants to pay and can pay for an angiogram? It doesn't mean na may pambayad is kailangan mo na siya yung angiogram. So, the only person na pwede mo siyang, na you will send for a coronary angiogram is the policeman. Number 18, 15 female with sinusitis, bulky and greasy stools. Their initial impression is cystic fibrosis. Okay, so it's very obvious naman kasi lung problem, sinusitis, and then GI problem with greasy stools. Among these options, like for example, Giardia lamblia, wala namang sinusitis yon, or COVID, wala rin ganun. Walang greasy stools ang COVID-19, and somatic syndrome, wala rin greasy stools. So by elimination, the answer is CF. So number 19, what is the distinctive finding in GPS? The correct answer is letter B, elevated protein levels without pleocytosis. The reason for that is there is increased permeability of the blood nerve barrier for protein, but there is no increased there is normal white blood cell count in the CSF, which is the reason kung bakit wala siyang pleocytosis, no? So it's also called albuminocytologic dissociation, elevated protein concentration in the CSF with normal white blood cell count. Number 20, the characteristic skin rash of Lyme disease is letter D, erythema chronicum migrans. Okay, so you have to know kung ano yung difference nitong mga erythema na to. Okay? So ang erythema multiforme is for drugs, marginatum is for rheumatic fever, nodosum is for these infections, and gangrenosum, ecthyma gangrenosum is for Pseudomonas. Now, hindi lang itong infections na to ang pwedeng mag-cause ng erythema nodosum. Marami pang iba. Like for example, this is from first aid. Erythema nodosum can be caused by sarcoidosis, coccidioidomycosis, plasmosis, TB, streptococcal infectious leprosy, and even IBD or inflammatory bowel disease. As you can see here, so this is inflammatory bowel disease, Crohn's disease, and ulcerative colitis. You can see erythema nodosum sa mga patients na yan. And maliban sa erythema nodosum being present sa Crohn's disease and ulcerative colitis, which is IBD, you can also see pyoderma gangrenosum sa patients na may IBD. So, ang pyoderma gangrenosum is different from ecthyma gangrenosum, which you can see sa mga patients na may Pseudomonas bacteremia. Okay, different yun, okay? Okay, I will just repeat it. Ang erythema chronicum migrans is a Lyme disease. Multiforme is a drugs. Marginatum is a rheumatic fever. Erythema nodosum is IBD and other infections tulad nito. Ecthyma gangrenosum is Pseudomonas. Pyoderma gangrenosum ay sa IBD rin. So, magkakaiba yung mga lesions na yun, but you have to remember those. Okay, and ang necrolytic migratory erythema is makita nyo sa glucagonoma. Okay, next is OB. Number 1, the following are absolute contraindications of OCPs except letter B, Okay? So, kasi ang 40-year-old with high risk for vascular disease is a relative contraindication. So, and the others are absolute. Smokers older than 35 years old, abnormal liver function, and embolism. Okay, those are absolute contraindications. Okay. Number two, which location? Okay, you have to remember these. Okay. I'll just leave it to you para i-memorize. Number two, which location of uterine fibroids is most commonly associated with heavy menstrual bleeding? That's submucosal. Okay. But the most common location is intramural. But the most common but the one that is commonly associated with heavy menstrual bleeding is submucosal. Okay. Cole-Exner bodies is associated with granulosa cell tumor. So the way I would remember that is using this mnemonic from first aid. Ang granulosa cell tumor is associated with Cole-Exner bodies. Give granny a call. No? Kasi granulosa, Cole-Exner. Give granny a call daw. Okay, so this is, itong mga next few numbers is parang isa-select mo kung 1 or 2. 1 or 2 or both. Okay, so medyo lumalabas nito sa sa PLE, no, na parang may set of options siya, tapos may different combinations nung set of options na yon, and then ilalagay niya dito sa letters. So hormone, letter of the options. So number 4, hormone that increases body temp, it's only progesterone. Produced in the ovary, it's both of them. Stimulates prolactin secretion, that's only estrogen. And produces thick cervical mucus, that's progesterone only. Okay. So this ligament provides the major support of the uterus and the cervix. The correct answer is cardinal ligament. Okay. And another thing that you should remember about the cardinal ligament is you can damage the ureter malapit sa cardinal ligament during uterine vessel ligation during hysterectomy. Okay? Pero hindi lang sa cardinal ligament mo pwede ma-damage si ureter. You can also damage the ureter during oophorectomy, kasi kanina is hysterectomy. During oophorectomy, pag niligate mo yung ovarian vessel. Okay? So those are the things that you have to remember. Okay? So this is from first aid again. What is the recommended amount of caffeine consumption in pregnant women? The correct answer is less than 200 milligrams per day. So this is from Williams. 21-year-old, yellowish vaginal discharge, services several red spots. The correct answer is treatment was Metro for 7 days. Okay. So this is a case of trichomoniasis dahil may strawberry cervix siya. Several red spots, yellowish vaginal discharge. Kasi if it were BV or vaginal bacterial vaginosis, the discharge would not be colored. The discharge would not be yellowish vaginal discharge if it were BV. Kasi ang discharge ng BV is thin white discharge with fishy odor. Ang trichomoniasis is frothy yellow-green foul-smelling discharge. So magkaiba sila ng characteristic ng discharge. So this is from first aid ulit, is very good na summary of the differences between BV, trichomoniasis, and candida vulvovaginitis. So I'll just leave it to you para aralin. Number 11, Sam had difficulty with delivery because of an impaction of the baby's shoulders behind the pubic symphysis, and then you ordered na mag all fours. This is called Gaskin maneuver. So ito yung Gaskin maneuver. We also have McRoberts maneuver, which is yung hyperflexion of maternal hips. Okay, and we also have Zavanelli maneuver, which is placing the infant's head back into the pelvis and performing CS delivery. Okay. Number 12, CTG revealed early decelerations. What is the etiology of early decelerations? The correct answer is head compression. So the way that pwede nyo itong matandaan is to write down veal, chop, mine, no, veal. So downwards, no, na mo isusulat yung veal, chop, mine, and then you'll just fill out yung mga nandito na terms, no. So variable deceleration is associated with cord compression or umbilical cord compression. Early deceleration is associated with head compression. Acceleration is okay. No, that's normal. Late deceleration is associated with placental insufficiency. So, ang tanong kanina is early deceleration. So, that's head compression. Okay? Next question. Patient na 35 weeks AOG came to the ER for severe headache and vomiting with 160/100 na BP. So, ang management dito is admit and deliver. Okay, so this is a case of preeclampsia with severe features on the basis of the BP na 160/100. Actually, kulang ito. Dapat is BP of 160/100 plus sinabi na may proteinuria kasi yung more than equal 160 and or DBP more than equal 100, that is preeclampsia with severe features. Pero dapat may proteinuria which is more than equal 300 per 24 hours or protein crea ratio of more than equal 0.3. Okay? So on the basis of the BP, kaya natin nasabi siya na preeclampsia with severe features. So ano ang treatment for preeclampsia with severe features? Delivery. Okay? Kasi delivery is the cure for preeclampsia. So it differs kung may preeclampsia with severe features siya na it differs yung management, whether kung yung patient ay more than equal 34 weeks of gestation or less than 34 weeks of gestation. For example, preeclampsia with severe features na more than equal 34 weeks of gestation, prompt delivery na yung patients na ganun. Preeclampsia with severe features na more than equal 34 weeks of gestation, prompt delivery. Okay? For all patients. Paano kung 34 weeks and paano kung less than 34 weeks na preeclampsia with severe features? Ang ginagawa natin is expectant management. So balik tayo sa patient natin, preeclampsia with severe features na dapat may proteinuria more than equal 300 mg per 24 hours. And more than equal 34 weeks na siya kasi 35 weeks na siya. Ang treatment is prompt delivery. Kaya ang answer is admit and deliver. Okay? Hindi tayo mag-expect at management. Mag-expect at management tayo pag less than 34 weeks na preeclampsia with severe features. Okay? Okay. So this, okay, number 14. Overdose ng magsulfate. Ano ang binibigay? 10 ml of 10% calcium chloride. Okay? Paano pag, paano naman pag hyperkalemia? Pag hyperkalemia is 10 ml of 10% calcium gluconate. Okay? So, dito naman overdose ng magsulfate is 10 ml of 10% calcium chloride. Okay? You should also memorize kung ano ang mga clinical presentation at different magnesium sulfate levels. Okay? The mechanism of copper as a major component of IUD is letter B. Okay? Why? Kasi itong A, C, and D ay mechanism of action ng LNG-IUS na IUD, no? Levonorgestrel. Okay? How about number 16? During pregnancy, cytologic changes such as the endocervical gland, hyperplasia, and hypersecretory appearance make it difficult to differentiate them from truly atypical glandular cells during a pap test. What is this cytologic change called? Arya-Stella reaction. So, ang Arya-Stella reaction, nangyayari siya normally sa pregnant. Okay? Which is why, sa mga pregnant na patients, it's difficult na to determine kung yung endocervical gland hyperplasia ay dahil ba sa normal pregnancy changes or dahil ba truly atypical glandular cells sila. Okay? Which is why, sa mga patients na pregnant na pinapap test, kailangan mo i-indicate na pregnant yung patient para ma-determine ng pathologist na yung endocervical gland hyperplasia, if present, could be Arya-Stella reaction, which is a normal pregnancy change sa cervical glands, or baka truly atypical glandular cells talaga sila, no? Okay, so that's Arya-Stella reaction. Okay, so ito yung definition ng Arya-Stella reaction. Pregnancy is associated with both endocervical gland hyperplasia and hypersecretory appearance, making it difficult to differentiate these from truly atypical glandular cells during pap test evaluation. Okay. Number 17, Who among the following should receive a single dose methotrexate as treatment for ectopic pregnancy? The correct answer is letter A. Why? Kasi, yung mga patients na pwede mong bigyan, yung mga patients na pwede mong i-medical management with methotrexate na patients na ectopic pregnancy, meron lang tatlong, as a general rule, ang pwede mo lang bigyan ng methotrexate is tatlo. Pag present itong tatlong to, okay? Less than 5 cm. Okay, less than 5 cm. And then, serum beta-HCG level na less than 5,000. And walang fetal heartbeat. Sila yung pwede mong bigyan ng methotrexate as a medical management for ectopic pregnancy. Balik tayo sa patient. 6 cm yung isa na may fetal heart tones. So, bawal. Kasi, dapat is walang fetal heartbeat, yun yung pwede mong bigyan ng methotrexate. How about ito? Mataas yung beta-HCG, 7,000. Bawal. Kasi dapat less than 5,000 para mabigyan mo ng methotrexate. Ito rin, may fetal heart tone, so bawal din. So ito naman, less than 5,000 ang beta-HCG, so ito lang yung patient. At walang fetal heart tone, so ito yung patient na pwede mong bigyan ng methotrexate as a medical management for ectopic pregnancy. Post-term pregnancy is defined as 294 days after LMP or 42 weeks. This is from Williams 26th edition. The definition of post-term pregnancy is more than equal to 294 days from the first day of the LMP. Okay, so aside from knowing kung anong definition ng post-term pregnancy, you should also know kung anong definition ng term at preterm. Okay, so ang preterm is up until the 259th day, and then term is 262 to 94, and then more than equal to 94 is post-term. Okay. The most common illicit substance used in pregnancy is marijuana. This is from 26 na Williams din. And the following descriptions refer to symmetrical IUGR except brain sparing. Kasi, and the others are true about brain sparing. So, true about symmetrical IUGR. So, this is symmetrical IUGR. So, pag symmetrical IUGR, both the head and the body ang proportionately reduced in size. Okay? Yung brain sparing, nangyayari lang siya sa asymmetrical IUGR. Okay? Okay, so ayun. So parang sa question na to, pinag-differentiate lang para malaman kung alam nyo yung difference ng symmetrical at asymmetrical IUGR. Okay, so I'll just leave this to you para aralin. Okay, so that's I hope you learned a lot from the discussion dito sa midterms na to, sa anatomy, sa biochem, pathology, surgery, IM, and OB. And see you in the next one. Bye.
All right, now let's move on to pediatrics. So generally, the feedback for your pediatrics parts of the PLE is that PEDS tends to be quite a fair part of the PLE. It covers a wide range of topics. Medyo mixed talaga siya, everything from GI to renal to cardio to neuro, etc. But they generally ask must-know and fair questions. Okay, so let's start. First question, a 10-day-old female infant was referred to you because of vomiting and a severely low sodium. You perform a complete physical examination and noted an ambiguous genitalia. Which of the following is true for this case? So you're presented with a lot of options, either mataas or mababa ang androgen or mataas or mababa ang cortisone and aldosterone, and different combinations. So the answer here should be letter B. So your high androgens, low cortisol, and low aldosterone. Okay, so even if you don't know the diagnosis, you can actually guess what the answer is based on the presentation of the patient. So let's look at it together so we can enhance our testmanship. We know that the patient is female, but the patient is presenting with ambiguous genitalia. What does this tell us? This tells us that there must be high levels of testosterone causing virilization or masculinization of this patient's genitalia. So therefore, eliminate na natin lahat ng nagsasabi na mababa yung androgens niya. So we will exit that and exit that. Okay, cross out C and D. So we're left with A or B. Now, what is our next clue? The patient has a severely low sodium. Now, what do we know is really important in the reabsorption of sodium, especially in your kidneys? That's your mineralocorticoids, the most important of which is your aldosterone. So therefore, if mababa ang sodium, it also means mababa ang mineralocorticoid activity, mababa si aldosterone. So therefore, we should eliminate letter A, which says na mataas ang aldosterone. So we're left with letter B, which is the correct answer. Now, if you do know the diagnosis, that's very good because the diagnosis is congenital adrenal hyperplasia, of which there are 3 common enzyme deficiencies causing it. But by far, the most common is your 21-hydroxylase enzyme deficiency, which is the case in this stem. So it is the most common presentation, and the patients who have 21-hydroxylase deficiency will present with hyponatremia, hyperkalemia, hypoglycemia as well, and of course your ambiguous genitalia. Let's look at the figure on the right to explain why this happens. So don't be intimidated by this figure. It's just to help us understand it, but I'll give you a mnemonic so that you can remember it in 5 seconds. This is just to help us understand and retain the rationale behind this question. Okay, so let's orient ourselves. This is the adrenal cortex. We remember that different layers of the adrenal cortex produces different steroid hormones. The deeper we go, the sweeter it gets. So the outermost layer is your G, zona glomerulosa. Then the middle layer is your F, which is your zona fasciculata. And then the deepest layer is your zona reticularis. The deeper you go, the sweeter it gets because in the zona glomerulosa, we produce mineralocorticoids, specifically your aldosterone, which is responsible for salt retention or sodium retention. Fasciculata, we produce your glucocorticoids, particularly your cortisol. And of course, in reticularis, we produce your sex hormones, which is the sweetest of the 3, and that is specifically your androstenedione. Okay? Now, in 21-hydroxylase enzyme deficiency, which is the most common of the 3 causes of CAH, what happens is we are blocking this step, okay? We are blocking this step. So therefore, progesterone cannot be converted into deoxycorticosteroid, and the further steps to produce aldosterone and cortisol are blocked. So you have a buildup of progesterone and 17-hydroxyprogesterone. Therefore, where do they go? They go to the path of least resistance, asan yung walang bara. And that is towards making androstenedione or your sex hormones, which is why you get high androgens, low cortisol, and low aldosterone, which is why patients who are female will present with virilization of their genitalia, hyponatremia, hyperkalemia, and hypoglycemia. Now, how do we remember all the 3 different types of enzyme deficiencies and what they present with? So let me try to bring up a blank slide. Let's see here. Okay, I don't know how to bring up a blank slide, but I'll use the space here. Okay, so I will make a small table. Let's make a table here. First column is your aldosterone presenting as hypertension. And then the second column is your testosterone. Okay, and then we'll list down the enzyme deficiencies that I mentioned: 21-hydroxylase deficiency, 17-hydroxylase deficiency, and 11-hydroxylase deficiency. Okay, now whenever there is a 1 in the digits of the number, you will put an upwards arrow. So the first digit is 2, it's not a 1. Second digit is 1, so you would put an upward arrow. Sa 17, ang first digit ang 1, therefore upward arrow here. And 11, both are 1s, therefore upward arrow here. So this will help you remember that in 21-hydroxylase deficiency, you get high testosterone but low aldosterone. In 17-hydroxylase deficiency, you get high aldosterone but low testosterone. And in 11-hydroxylase deficiency, you get hypertension and high testosterone. Now, I just wanted to focus on the 11-hydroxylase deficiency and explain this a little bit, because if we look at the slide here, 11-hydroxylase deficiency is actually important in the final step of producing cortisol and also in the downstream steps of producing aldosterone. So, Doc, if 11-hydroxylase is deficient, why would we still have hypertension in these patients? So the reason is, if I block this step, okay, we get a buildup of 11-deoxycortisol. okay, or 11-DOC. Now, this steroid precursor, even if it's not cortisol yet, even if it's not the final version of the steroid hormone, it actually has very high amounts of mineralocorticoid activity. So even if it's not a mineralocorticoid, it can act on the MC receptors, therefore mimicking hyperaldosteronism, causing hypertension, hypernatremia, and hypokalemia. Okay? So this will hopefully help you never forget the different types of congenital adrenal hyperplasia. Next, this is the most common malignant brain tumor in children. Is it glioblastoma, schwannoma, medulloblastoma, or metastases? So the most common malignant brain tumor in children is your medulloblastoma. So the medulloblastoma is most often found in the cerebellum and is the most common malignant tumor in children. It has a predilection towards males. And the pathology of these medulloblastomas, if you look at it under a microscope, you would typically see your Homer right rosette. So this is a buzzword for medulloblastoma. It's a circular pattern of tumor cells surrounding a center of neutrophils. So in order to visualize the extent of the lesion, we would of course order an MRI in these patients. Okay. Number 3, a first-time mom was asking your advice about how she should store breast milk for her baby. If she stores it in a regular refrigerator, how long will its shelf life be? 4 hours, 1 week, 2 weeks, or 3 months. So in a regular ref, it will last for 1 week. So according to the Philippine Pediatric Society, if you're at room temperature of less than 25 degrees Celsius, it can last for 4 hours. Above 25 degrees Celsius, definitely only 1 hour. Refrigerator, which is about 4 degrees Celsius, 8 days. If it's a one-door freezer, it can last 2 weeks. Two-door freezer, it's 3 months. And a deep freezer, which can go as cold as negative 20 degrees Celsius, it can last 6 months. Okay. Which among the following is the appropriate deworming plan for children 1 to 2 years old? Mebendazole 500 milligrams once a year, albendazole 200 milligrams single dose every 6 months, albendazole 400 milligrams single dose every 6 months, or mebendazole 1 gram single dose? Our answer here is letter B. So in deworming, according to our national deworming program, the recommended routine for all children aged 1 to 12 years old is as follows. If the patient is between 12 months to 23 months, so 1 to 2 years old, we would give 200 milligrams single dose every 6 months. If the patient is 2 years and above, we would give 400 milligrams single dose every 6 months. If we were to give mebendazole, which we can start for patients 1 year and above, we would give 500 milligrams single dose every 6 months. So in the choices kanina, mebendazole was given as every year or as a single dose entirely. So if we give mebendazole, it should still be every 6 months. So when do we not choose to deworm children? It's when they have severe malnutrition, high-grade fever, profuse diarrhea, abdominal pain, serious illness, or hypersensitivity to medications. What is the role of supplemental zinc therapy in acute diarrhea? Does it help kill the etiologic agent, allow faster rehydration, limit the infection to the intestines, or reduce severity and duration of the illness? So the answer here should be letter D. It reduces severity and duration of the illness. So it also prevents subsequent episodes of diarrhea. So what is the dosing of supplemental zinc therapy according to our IMKI guidelines? So up to 6 months, we should give half a tablet every day for 10 days. If it's over 6 months, we give 1 tablet per day for 10 days. And again, this is to reduce the severity and duration as well as prevent subsequent episodes of diarrhea. A 12-year-old male has been having a fever and a cough for the past 2 days, for which he was being treated with an antibiotic. However, early this morning, he noticed blood in his urine. What is your consideration? Is it IgA nephropathy, side effect of antibiotics, Goodpasture syndrome, or hemolytic uremic syndrome? So our answer here should be IgA nephropathy. So bakit IgA nephropathy? So this patient presents with what looks like a viral infection, fever, and a cough for the past 2 days, and then right after develops hematuria. So that should prompt us to think of IgA nephropathy, where you get sudden onset frank hematuria, usually with a preceding respiratory tract infection and a normal C3. Do not confuse this with PSGN, okay? If the clinical picture is hematuria right after an upper respiratory tract illness, think IgA nephropathy. If it is hematuria about 2 to 3 weeks or more than a month after a respiratory infection, think of post-strep glomerulonephritis. In addition to that, in IgA nephropathy, you will have normal complement levels, whereas in PSGN, you will have depressed complement levels, okay? So in terms of IgA nephropathy, it is an immune-mediated disease where you get increased IgA or immunoglobulin antibodies depositing in your kidneys. Under local microscope, it would present as focal proliferation. Under immunostaining, you would find diffuse mesangial deposits of your immunoglobulin. And under electron microscope, you would also find mesangial deposits. Okay, number 7, scorbutic rosary. Where do you find it? A, in your vitamin D deficiency, B, in your vitamin C deficiency, C, vitamin B1, or D, vitamin B12. The answer here should be letter D, vitamin C deficiency. So don't be confused. Not all rosaries are caused by rickets. So your scorbutic rosary is seen in scurvy, which is from a vitamin C deficiency, and your rachitic rosary is seen in rickets caused by a vitamin D deficiency. So according to Nelson's, the scorbutic rosary though is distinguished because it has a sharper angulation at the costochondral junction. I think it's very difficult to tell from the photos whether it's scorbutic or it's rachitic, to be honest. Now, other findings seen in rickets or in vitamin D deficiency, you would have enlarged wrists and ankles, and this is because of enlargement of the growth plates. And you would also sometimes find a Harrison's groove, which is a horizontal line in the subcostal area. And this happens in rickets because you have very soft ribs that are being pulled down by the diaphragm during inspiration. Okay, so don't forget scorbutic rosary, scurvy, rachitic rosary, rickets. Mizzy, 12 years old, consulted because of generalized vesicular lesions. All of the following are your differential diagnoses except herpetic gingivitis, impetigo, varicella, or hand, foot, and mouth disease. So the best answer here would be impetigo, primarily just because of the description of the lesions as vesicular. So definitely in gingivitis or any herpetic lesions, they will always be punched out and vesicular. Varicella, definitely vesicular lesions. Hand, foot, and mouth disease are also commonly vesicular lesions as well. Impetigo can sometimes present as vesicular, but it is usually honey color crusted plaques or pustules. Okay, so impetigo, or your mama sore in Tagalog, is the most common skin infection in children. It is typically localized to the area around the nose and the mouth, and it has the classic honey-crusted lesions. It can also be caused by your group A strep, but the usual cause for impetigo is your Staph aureus. Now, they can be bullous or non-bullous. When they are bullous, they present like this, so very flaccid, large, transparent bullae, whereas if they are non-bullous, they will present like this. Okay? Right. A 13-year-old male was brought to the emergency room because of seizures. This is the first time this has happened. He was afebrile and without any known comorbidities. The initial emergent therapy for this case, is it IV levetiracetam, IV phenytoin, IV diazepam, or intranasal midazolam? So our answer here would be letter C, IV diazepam. So as an initial management for a patient who is not a known epileptic, not in status epilepticus, we would give some benzodiazepines, particularly IV diaz, IV liraz, or IV midazolam. So diazepam, remember, is highly lipophilic. It can distribute quite rapidly to the brain and then is quickly cleared out. So of course, as with any benzodiazepines, we just have to be careful of the respiratory depression that it can cause. So if we're unable to get IV access, for example, because the patient is having an active seizure or very difficult to cannulate, we can also give it rectally. Okay, so initial therapy is IV benzodiazepine muna before going into any of your anti-epileptic drug infusions. Okay. Neonatal sepsis is most likely to occur in the following conditions except post-term pregnancy, a membrane that has ruptured for more than 18 hours, a maternal urinary infection 1 day prior to delivery, or an APGAR score of 4, 7, and 5. The answer here is an APGAR score of 4, 7, and 5. A, B, and C very clearly contribute to the development of neonatal sepsis. So remember, what are the risk factors for neosepsis? Prematurity, one of the single most significant risk factors due to a very poorly developed immune system. Premature rupture of membranes, especially if it has lasted for more than 18 hours. Maternal peripartum infections, so things like urinary tract infections, fetal and intrapartum distress, especially if they come out meconium stained or if there is traumatic delivery. Invasive procedures, metabolic factors, or previous delivery of a neonate with GBS or group D streptococcal disease, specifically your strep agalactiae, and multiple gestation. So remember, your APGAR score does not really help with prognostication, so it's not really a good answer for the previous question. It will just let us know how well the infant is responding to neonatal resuscitation when it is being done. So Lalaine became extremely worried because her newborn baby vomits every time she tries to breastfeed. She also noticed a palpable 2-centimeter mass on the baby's abdomen. Your initial consideration will be, so guys, ang daming buzzwords, this should be automatic na. Letter C, pyloric stenosis. Okay, so remember, postprandial vomiting, abdominal distension, and an olive-shaped abdominal mass, ding, 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 think of your pyloric stenosis. Essentially, you have a hypertrophic pyloric stenosis. So parang yun yung mass na nafe-feel sa abdomen and it's blocking the gastric outlet. Therefore, whenever you feed the baby, sinusuka niya lang. Okay, so barium studies will show a shoulder sign or a double track sign, which is essentially just the lining of this hypertrophy in the pyloric area. So you would confirm it with an ultrasound or with a barium swallow study, whichever works. Okay. What is the minimum age for influenza vaccination? Is it 6 weeks, 10 weeks, 6 months, or 9 months? So the answer is 6 months. So according to our National Childhood Immunization Schedule, the minimum age for your flu vaccine is 6 months. Now, what are some other minimum ages for vaccines that we need to remember? The Japanese encephalitis, we can only give at 9 months. Rotavirus at 6 weeks, and chickenpox or varicella at 12 months. So with the childhood immunization schedule, we just have to keep looking at it again and again and again and again, and just remember the exceptions. Unfortunately, wala pa akong mnemonic to really help memorize a childhood immunization schedule other than just keep looking at the schedule until it eventually sticks to your brain. Number 13, Apollo, a 4-year-old male, uses his hands to push on his legs to be able to stand up. His calf muscles were noted to be atrophied. What is your diagnosis? Is it A, cerebral palsy, B, Duchenne muscular dystrophy, C, Becker's muscular dystrophy, or D, spinal muscular dystrophy? So our answer here should be letter B. So another potential answer would have been letter C, Becker's muscular dystrophy, but the reason DMD or Duchenne's is more appropriate, look at the patient's age. The patient is very young, but is already exhibiting severe signs of muscle weakness. So remember, Duchenne is a more severe version of your Becker's. Therefore, mas appropriate answer ang DMD. So in Duchenne muscular dystrophy, you get an X-linked recessive abnormality of your dystrophin gene. And yung sinabi natin kaninang sign of he had to push up on his legs to stand up, that is what we call the goer sign. Because they have very, very weak calf muscles, they need extra support in order to get themselves up. So this is usually evident at 3 years of age and is full-blown by 5 to 6 years old. So the previous STEM mentioned that there was muscular atrophy. But remember, guys, in patients with Duchenne muscular dystrophy, the muscles are atrophied, but the calf will actually look pseudo-hypertrophied because the muscles are dead and they are being replaced by your adipose tissue. So the muscle itself is atrophied, but if you look at the calf as a whole, mukha siyang malaki, but it's pseudo-hypertrophy. That is just adipose tissue replacing your dead muscle. Your Becker's muscular dystrophy, as I mentioned, is a milder form of DMD, so it presents later and with less weakness compared to your Duchenne's. Next, the major mechanism of phototherapy in the treatment of jaundice is photooxidation, conjugation, photoisomerization, or photoreduction. So the best answer here is letter C, photoisomerization. So letter A is also one of the mechanisms in the treatment of jaundice, but the major mechanism is letter C. So according to your Nelson's, essentially in phototherapy for babies with neonatal jaundice, what happens is you get a buildup of unconjugated bilirubin, usually because the enzymes responsible for conjugation are still immature. So this unconjugated bilirubin is not water-soluble, so they deposit into the skin. So in order to convert it into the water-soluble form so that we can excrete it into the bile or the urine, we undergo phototherapy. And it is through photoisomerization that we can convert it into the water-soluble form, excrete it into the urine, and resolve some of the jaundice. Okay? Next, a 15-year-old male consulted because of generalized weakness, right upper quadrant abdominal pain, nausea, and vomiting. He appears yellowish. Liver biopsy was done, which showed dark pigmentations. What is your diagnosis? Is it Rotor syndrome, Dubin-Johnson syndrome, Crigler-Najjar, or your Gilbert syndrome? So all of these are syndromes associated with hyperbilirubinemia. However, the buzzword here is dark pigmentations on liver biopsy. That is your letter B, Dubin-Johnson syndrome. So let's differentiate the different syndromes causing hyperbilirubinemia. Let's starting with the most common, your Gilbert syndrome. So this is a benign autosomal recessive mutation in your UGT1A1 gene. Essentially, you have decreased activity of your UDP-GT. Therefore, you get a buildup of unconjugated bilirubin. However, this is typically very mild. It is only mildly elevated, and the jaundice only presents during periods of fasting or stress. You will not typically present with kernicterus kasi again, this is mild. Your Crigler-Najjar naman is also autosomal recessive, also a mutation in the same gene, but it has two types, type 1 and type 2. Type 1 completely absent, type 2 decreased lang ang activity. Because type 1 is completely absent, you have really severe jaundice, really severe buildup of unconjugated bilirubin, which can then cross the blood-brain barrier and cause your kernicterus. Sa type 2, it's just a decreased level of the enzyme. You typically will not present with as much jaundice, nor with that much kernicterus. So the treatment for type 1 Crigler-Najjar syndrome in very severe cases is usually a liver transplantation. Dubin-Johnson is a chronic but mild, usually presents in adolescents, syndrome of hyperbilirubinemia. The most high-yield part of the Dubin-Johnson syndrome is you have to remember that on liver biopsy, it will show dark pigmentations of the liver. So yun lang yung one of the confirmatory things to differentiate Dubin-Johnson from the other syndromes. Lastly, your Rotor syndrome is quite similar to your Dubin-Johnson as well. However, on liver biopsy, it will be normal. Okay. Next, in IV drug users, this is the most commonly infected valve in infective endocarditis. Is it mitral, aortic, tricuspid, or pulmonic? In IV drug users, the answer is letter C, tricuspid. So remember, in normal infective endocarditis, it's MATP, mitral, aortic, tricuspid, or pulmonic. However, among IV drug users, what's happening is you're injecting drug, you're probably using a dirty needle. If you inject it in the peripheral circulation, the venous return, does it go back to the left side of the heart or the right side of the heart from the peripheral circulation? Remember, it goes to the right side of the heart. Therefore, the first valve that will bear the brunt of all that infection is your tricuspid valve. Okay? Next. 17. Curtis has been febrile for 1 week now. When the fever started, he had a slight cough and colds with redness of the conjunctiva. 2 days later, he developed a maculopapular rash on the trunk. Consult was done via telemedicine with the consideration of measles and pneumonia. He was prescribed antibiotics, but this afforded no relief. On PE, he has cervical adenopathy and hyperemia of the oral mucosa. What is our diagnosis? Chickenpox, dengue fever, Kawasaki disease, or rheumatic fever. So quite clearly, it's pointing us towards Kawasaki disease. Remember, guys, your Kawasaki disease, don't forget the crash and burn. So burn is a fever for at least 5 days and 4 of the following. So C, conjunctivitis, is it's usually bilateral, bulbar injection without exudates, rash of any form, adenopathy, so cervical adenopathy, strawberry tongue and other oropharyngeal changes. You will usually have very red, very cracked, very fiery swollen lips. And you will also have hand changes, things like peeling and desquamation of your hands and your soles. Okay. Now, for this patient who has Kawasaki's disease, when will you request for a repeat 2D echo given that his initial result is normal? Will you do it after 24 hours, 2 weeks after the initial 2D echo, 2 weeks after onset of illness, or 8 weeks after onset of illness? According to Nelson's, we do it 2 weeks after onset of illness. So why do we need to do a 2D echo in the first place? So remember, Kawasaki's disease, especially the subacute phase, is associated with desquamation, thrombocytosis, and the development of coronary artery aneurysm. Now, this coronary artery aneurysm carries the highest risk of sudden death in patients in whom the aneurysms have developed. So it's a rare complication, but it is very, very dangerous when missed because it will cause sudden death. So we perform a 2D echo at the time of diagnosis, and then we repeat it 2 to 3 weeks after the illness. If that is still normal, we repeat it again after 6 to 8 weeks from illness onset. And remember that we also give aspirin in these patients as an antithrombotic therapy, especially in the subacute and chronic phase of the illness. It is the only disease wherein we would give aspirin to children. Okay. Next, a pregnant patient has contracted rubella. Her child is most likely to be at risk of developing which heart condition? Ebstein's anomaly, TAPVR or TAPVR, TOF, or patent ductus arteriosus. Among the options, our best answer is letter D, PDA. So let's not forget the fetal heart defects associated with maternal conditions. For example, your rubella is associated with a patent ductus arteriosus. Diabetes is associated with transposition of the great arteries. Maternal lupus can be associated with a complete heart block. Aspirin can be associated with pulmonary hypertension because NSAIDs, like your aspirin, can cause premature closure of the patent ductus arteriosus, therefore causing premature pulmonary hypertension. And lithium, for example, can also cause your Ebstein anomaly. Okay. Next and last question for pediatrics. A 2-month-old baby was readmitted to the hospital because of recurrent pneumonia, which does not respond to first-line antibiotics. She has been admitted multiple times before because of the same reason. On PE, you noticed white thrush on her tongue that cannot be scraped off. Which enzyme is the most likely defective in this disease? So our answer here, this patient has recurrent infections. Our answer here is letter A, adenosine deaminase, which causes SCID or your severe combined immunodeficiency, causing recurrent infections in very young patients. Let's look at the other options. Ano ba si 1720 lyase deficiency? It's the same as your 17 alpha hydroxylase deficiency, causing your congenital adrenal hyperplasia. Your PAH deficiency, this is your phenylketonuria, which causes intellectual disabilities, jerky movements, and lighter skin. Your galactose 1-phosphate uridyl transferase deficiency is, of course, your galactosemia, okay, which is a galactose intolerance or inability to metabolize galactose, leading to failure to thrive, jaundice, and intellectual disability whenever the child is exposed to galactose. So adenosine deaminase deficiency is associated with SCID. About 50% of SCID cases are due to deficiency of ADA or adenosine deaminase. What happens is whenever this enzyme is deficient, you have a buildup of deoxyadenosine and deoxy-ATP inside your lymphocytes. This causes cell death of your lymphocytes. Therefore, the patients are unable to mount a proper immune response. So infants with SCID will usually succumb to the recurrent infections within the first 2 years of their life. So they are very prone to recurrent bacterial infections, recurrent fungal infections, and recurrent viral infections. So that's it for your pediatrics part of the midterm examination. Okay, so last one, guys, preventative medicine and public health. So this subject has always been very difficult to prepare for. So it's always a mix of one, either your biostatistics and your epidemiology, two, spill over from the other 11 subjects. So sometimes you'll find a random micro question, a random pharma question, a random pedia question there, and three, sometimes just random questions that you can't always prepare for. So don't be too stressed when you prepare for Prevmed. Of course, don't ignore it as a subject, but just focus on what you can prepare for, which are the biostats, the policies that always come up, and of course, study for the other 11 subjects, which will help you answer this subject as well. Okay, so let's go to number 1. First question, the recommended duration for isolation for probable or suspected cases of monkeypox. 5 days, 10 days, 14 days, or 21 days. So the best answer here is letter D, 21 days. So monkeypox, or now it has been renamed to Mpox because monkeypox was associated with racist and stigmatizing language. At the time when it was a massive global concern, the recommendation by the CDC was isolation for 21 days. And this was also the recommendation that was adopted by the Philippines. However, now that Mpox is sort of fading from sight and we are no longer as concerned about Mpox as we were before, I believe the current CDC recommendations is just to wait until the lesions resolve and you feel better. However, because that was not in the options previously mentioned, we will stick to what was explicitly mentioned by CDC in one of the previous guidelines, which is 21 days. The following are factors which decrease prevalence rate except shorter disease duration, in-migration of susceptible people, out-migration of cases, or high case fatality rate. Our answer here is definitely letter B, in-migration of susceptible people. So what are the factors that influence your prevalence rate? So remember, your prevalence is computed by the number of people who have the disease or the characteristic of interest over the total number of people in that population. So what are the things that increase it? So longer duration of disease. So this makes sense. If you have a chronic disease like hypertension, for example, prevalence would also definitely go up because the patients carry it with them for a very long time. Compare it to the prevalence rate of something self-limiting, for example, like bacterial pneumonia. Prevalence would go down as long as patients heal from the bacterial pneumonia. Prolongation of life of patient without cure. So this is again some of your lifestyle diseases like diabetes and hypertension. We have learned how to prolong their lives, but we still haven't really learned how to perfectly cure hypertension and diabetes. So prevalence just keeps on increasing the longer these unhealthy people or sick people live. Increase in new cases, that makes sense. In-migration of cases would, of course, increase your numerator, and out-migration of healthy people would decrease your denominator. Therefore, tataas yung prevalence rate mo. In-migration of susceptible people will also increase your prevalence rate because they are more likely to get ill, and improve diagnostic facilities because you're picking up more cases, so the numerator goes up. It is decreased by shorter duration of disease, as I explained earlier. A high case fatality rate, because if these people with the disease are dying, we won't be able to count them in the numerator as people who currently have the disease. Decrease in new cases, of course. In-migration of healthy people, this would increase the denominator with a relatively stable numerator, so bababa ang prevalence rate. Out-migration of cases, numerator would go down, and improved cure rate of cases as well. Okay, so the answer in the previous question was in-migration of susceptible people. This will increase prevalence rate. While doing your regular afternoon rounds, you heard an announcement of cold silver. This means A, severe weather, B, to evacuate immediately, C, bomb threat, or D, the presence of an active shooter. The answer is letter D. So what are the hospital color codes? So disclaimer, these are not standardized and may vary per hospital, but generally, if it's code blue, it's a medical emergency, a code. If it's code red, it could be a smoke or fire. Code black is a bomb threat. Code pink is an infant or a child abduction. Code orange is a hazardous spill incident. Code silver is an active shooter. So the way I remember this was a silver bullet, so active shooter. I remember code pink, I was imagining a small girl in a pink dress na na-abduct. So code pink, infant or child abduction. Code violet, violent. So you kind of remember it. It's a violent or combative individual. Code yellow, disaster. Code brown, severe weather. Code white, evacuation. And code green, emergency activation. So these are, it's quite difficult to memorize these because we don't really use this in our current hospitals, but they have come out in some of the past boards. So it might be worth going through this at least once or twice before you enter the exam room. Next, which of the following is incorrectly matched regarding the food fortification law of the Philippines? Is it rice and vitamin A, refined sugar and vitamin A, cooking oil and vitamin A, or wheat flour and iron? The answer here is letter A. So the food fortification, there are certain foods in the Philippines that should be fortified as a mandatory thing. So most of them are fortified with vitamin A. That's your wheat flour, your refined sugar, and your cooking oil. So that will remind you that vitamin A is associated with harina, asukal, mantika. Si rice naman is fortified not with vitamin A but with iron. Si wheat flour is also fortified with iron. So okay, so the answer is rice, vitamin A. It should be rice fortified with iron. Okay. This parenting style often results to an impulsive, rebellious, and low-achieving child. Is it a democratic parenting, rejecting parenting, permissive parenting, or uninvolved parenting? Now, guys, remember, this is not real life. This question is not real life. It is just supposed to mimic the Philippine licensure exam, which will sometimes ask these types of questions. Obviously, not one parenting style will automatically lead to a certain child. But anyway, for the purpose of the PLE, our answer is letter C, permissive parenting. So according to our to what we know about preventive medicine, parenting styles can be either authoritarian, authoritative, permissive, or uninvolved. Now, in permissive parenting, we generally don't reinforce rules. We always shrug and say kids will be kids. So we let the child preferences take priority over our ideals. And so, according to preventive medicine, this can result in children who are impulsive, rebellious, and low achieving. Again, this is not really real life, but for the purpose of the boards. Okay, number 6, you prescribed 500 milligrams of paracetamol with a label. Take 1 tablet every 4 hours for a fever of 37.4 degrees Celsius or up. What type of data is temperature? Is it a ratio data, interval data point, ordinal data point, or nominal data point? So this is your interval data point. So remember that in comparing ratio versus interval, in interval data, we are measuring it on an interval scale, which means that it has a consistent and an equal interval between values. So if I put a scale here, okay, it means that it makes sense that 1 degree versus 10 degrees, that's 9 degrees apart. And the difference between 1 and 2 degrees and 2 and 3 degrees is equal. It's 1 degree. Okay. However, in interval values, the value of 0 is arbitrary. So if I say it's 0 degrees Celsius, it doesn't mean that there's no temperature at all. In fact, you can have negative temperature as well. You can have negative degrees Celsius or negative degrees Fahrenheit. In ratio value points, the 0 is absolute. If you say you have 0, you really have none of that thing at all. In ordinal, these are things that are ranked, so first, second, third, and fourth. And in nominal, these are things that are categorized by name or by category. So things that start with letter A are in that group, things that are pink, things that are blue. Okay, next. Same type of question, pero yung tanong naman, what type of data point is the dosage of your paracetamol? So in this case, it is a ratio data point because the 0 is absolute in this case. Remember, in interval, the 0 is arbitrary. In ratio, the 0 is absolute. So if you give 0 milligrams of paracetamol, you're not giving any paracetamol at all. So it makes sense na yes, ratio siya. What are other examples of ratio data points? Money or income. If you say that you have 0 pesos, you really have no money at all. It is absolute 0. Okay? Next question. It has become your routine to educate all your female patients to do self-breast examination every after their menses. This is what type of disease prevention? Is it primordial, primary, secondary, or tertiary? So the answer here is letter C, secondary. So in terms of the levels of prevention, we have primordial, primary, secondary, and tertiary. So let's focus on the question kanina, which was early screening of breast cancer. Remember, in secondary prevention, there is already a latent disease, and our goal is to diagnose it very early and to treat it as quickly as possible. So these, of course, include your screening programs, which involve breast or self-breast examination, because the self-breast examination will only work if you can actually find a lump there, which would suggest that there is either early breast cancer or a benign breast mass, which should be diagnosed and treated accordingly. Now, let's go through the different levels of prevention. Primordial prevention targets the entire population, including individuals who have no risk of any signs of disease. So these are very broad health determinants, things like policies that create supportive environments for health. And the main goal is to minimize future hazards. In primary prevention, we are focused on preventing diseases in individuals who are at risk or are susceptible to a specific condition. So it aims to intervene before the disease starts, preventing its occurrence. So these are things like childhood vaccinations to prevent infectious diseases, smoking cessation programs to prevent lung cancer, etc., etc. Tertiary naman are for patients who already have symptomatic diseases, and our goal in this point is disability limitation and rehabilitation. So the disease has already happened. Either it was a late diagnosis or late treatment, and they're very symptomatic. We are just trying to rehabilitate them and limit the worsening of their disability. So the goal here is to soften the impact of an ongoing illness or injury. Next question, RA 11469, aka Bayanihan to Heal as One Act, has been enacted to declare a state of national emergency in the country during the COVID-19 pandemic. Laws such as this one is what type of prevention? Primordial, primary, secondary, or tertiary? So again, basta policy or laws, generally the answer should be letter A, or primordial. Just note that this can also be considered as secondary or tertiary prevention, and I'll show you why in the next slide. But whenever it's a law or a policy as a blanket act, generally they are primordial. So the main goal of RA 11469 was to mitigate and contain the transmission of COVID-19. So even in patients who weren't at risk, it was a very general population thing, a blanket population thing. There were some secondary prevention measures put there as well, such as providing ample health care, including medical tests and treatment, so early diagnosis and early treatment for patients who do have it, and to undertake a recovery and rehabilitation program for those patients who eventually did develop symptomatic COVID-19. So, okay, this is a reminder of your levels of prevention. Okay, so number 10, which graph will you use to depict comparisons between the number of pediatric versus adult patients who received bivalent COVID-19 vaccine and developed side effects? Is it A, a pictograph, B, a scatter plot, C, a frequency polygon, or D, a line graph? So the best answer here would be letter C. So a frequency polygon is used for comparison of two populations, like the adult versus pediatric population. A scatter plot is more used to correlate two quantitative variables. So for example, we want to correlate age and mortality rate in patients who have developed COVID-19. Line graph is more used if we want to see trends or changes in data over a period of time. So that would be when we would use a line graph. But for comparing these two populations, the best answer would be a frequency polygon. Ray was bitten on the leg by their neighbor dog. He immediately washed the wound with soap and water. He tried to induce bleeding because he saw a TikTok tutorial about it. How would you categorize the wound? Category 1, 2, 3, or 4. So our answer here is category 2. The buzzword that should point you to category 2 is induced bleeding, hindi siya spontaneous bleeding. So to understand bakit relevant yung induced bleeding, we have to go through the rabies exposure categories by the National Rabies Prevention and Control Program. So for category 1 exposures, this is usually involving feeding or touching an animal. So things like, licking of intact skin, exposure to a patient with signs of rabies. So really no real risk of you developing or getting infected with rabies as well. So the management here would just be to wash the exposed skin. There is no need to vaccinate. There is no need to give immunoglobulin as well. For category 2, again, the categories of wounds that belong to this are those that include induced bleeding, so very minor or superficial wounds that wouldn't have bled if the patient wasn't squeezing it or forcing it to bleed. So these are usually from nibbling of uncovered skin with or without bruising. However, if it is in the head and the neck area, manage it as category 2. So even if it's induced bleeding, pero it's somewhere on the face, somewhere on the neck, consider it as category 3. So the management for category 2 is, of course, still wash the wound, but you would also start the vaccine immediately. Complete the vaccination regimen until day 7, but you do not need to give the immunoglobulin. For category 3 naman, so these are things that are spontaneously bleeding even without inducing the bleed. So transdermal bites like puncture wounds, lacerations, or avulsions. If there are licks on broken skin or mucous membrane, so if you have a pre-existing wound, tapos nilaan ng dog, for example, exposure to a patient with rabies through bites or contamination of mucous membrane, so their saliva gets into your eye, etc. Unprotected handling of infected carcass, ingestion of raw infected meat, exposure to bats. So even if there's no biting, as long as you've been exposed to bats. And all category 2 exposures on your head and neck area are considered category 3 exposures to rabies. So in addition to giving the full vaccine regimen, we would also administer your immunoglobulin immediately after vaccination against rabies. So remember that rabies, once it develops into a full infection and you're unable to catch it very early, is 99.99999% fatal. There's been very, very few handful of cases of people in the whole world who have survived a rabies infection. So it's really important to give appropriate prophylaxis when necessary. Immunization against cervical cancer is recommended up to what age? 10 years old, as long as with menstruation, 26 or 30 years old. The answer is 26 years old. So ano nga ba yung immunization against cervical cancer? Remember, it is your HPV vaccine, the most popular one being your Gardasil vaccine, for example. So the HPV vaccine, according to the CDC, is usually given in 2 doses, 6 months apart, ideally for those aged 11 to 12. We do give 3 doses for the patients who are aged above 15 and up to 26 years old. However, above 26 years old, we do not routinely recommend this vaccine anymore. Now, quick question before I proceed to explain why. Is the HPV vaccine only given to females? So no, remember, it is given to both males and to females. Now, when would we give HPV vaccination to those aged above 26 years old? So if they are not already vaccinated and they decide to get the HPV vaccine after speaking with their doctor about their risk for new HPV infections and the possible benefits of vaccination for them. So what's a concrete example? Let's say it's a 30-year-old female. Prior to her wanting to get the vaccine, she has never had any sexual contact, never had any sexual intercourse. But now let's say that she has a new partner, she would like to explore her sexuality, she would like to participate in intercourse, and she would definitely benefit from an HPV vaccination. Because it's a vaccination, it will do nothing for an HPV infection that is already there, but it will prevent HPV infections in the future or further down the line. So if it's a 30-year-old female, never had sex before, now wants to have sex, definitely the HPV vaccine would be a good idea. This family assessment tool measures one's level of satisfaction with their family relationships. Is it the Minukin map, Scream, Family Apgar, or your family lifeline? So remember the answer here, kapag satisfaction, family satisfaction, that's your family Apgar. So Apgar is an acronym that stands for adaptation, partnership, growth, affection, and resolve. And you typically score this by giving people a questionnaire where they either answer almost always, some of the time, or hardly ever. Okay, so some of the time will give you 1 point, almost always will give you 2 points, and hardly ever will give you 0 points. And that would let you know how functional or dysfunctional a family is. So the questions are all about satisfaction with certain parts of a family dynamic. So for example, with adaptation, we would ask the person, are you satisfied with the help that you receive from the family when something is troubling you? Because we're trying to check whether they can turn to family when something is wrong. With partnership, for example, you would ask, are you satisfied with the way my family discusses items of common interest and shares problems with me? Because we want to talk about things and sharing problems under partnership. And so on and so forth for growth, affection, and resolve. Okay, so basta family satisfaction or satisfaction of an individual in their current family dynamic, that should be your APGAR. Next, according to Kubler-Ross, guilt is the primary emotion in this stage of grieving. Is it denial, anger, bargaining, or depression? So the answer here is bargaining. So don't forget the grief cycle or the stages of grief. You have your dabda, you have your denial, your avoidance, your bargaining, your depression, and your acceptance. Now, when it comes to guilt, usually this is seen in the bargaining stage. So you feel very overwhelmed, you feel very helpless, and you feel very guilty as well over the grief or over what had happened that causes the grief. Okay. The following are the 3 thrusts of the Universal Healthcare Law, except attainment of the MDGs, attainment of the SDGs, financial risk protection, and access to quality health facilities and services. The answer is except letter B. So the 3 thrusts of the UHC law or the kalusugang pangkalahatan are, number 1, to improve financial risk, to achieve Millennium Development Goals, and to improve access to quality healthcare facilities. So they believe that by implementing these 3 thrusts towards kalusugang pangkalahatan, we can get an improved health status of all Filipinos. This phase of COPAR is the most crucial stage since it is during this time that the people are mobilized through the creation of the community health organization. Is it pre-entry phase, entry phase, formation phase, or organization building phase? For some reason, lagi tong tinatanong na question, and the answer is organization building phase. So remember, ano nga yung COPAR? It is the Community Organizing Participation Action Research. And the most important phase, because this is where we mobilize people, is your organization building phase, okay? And this is when we mobilize our human resources to create the community health organization. Next, Weng has completed 6 months of anti-TB treatment in the year 2019 and was declared cured. However, during her pre-employment screening, she was once again diagnosed as an active case. Treatment was started. How would you classify this case? Is it a relapse? Is it treatment after failure? Is it treatment after being lost to follow-up? Or previous TB outcome unknown? So natapos niya yung 6 months of anti-TB in 2019, declared cured, ngayon bumalik. The answer is letter A, relapse. So according to our Manual of Procedures for the National Tuberculosis Program, relapse is defined as a patient who was already previously treated for tuberculosis, which is the patient in the previous stem, has been declared cured or treatment completed. So even if there was no evidence of cure, as long as natapos na yung full course of treatment in their most recent treatment episode, and then is recently or presently diagnosed again with bacteriologically confirmed or clinically diagnosed TB. So the criteria you have to meet is, again, previously treated, declared cured or treatment completed, and again, presently diagnosed ulit. So that would be a relapse. Gold standard for diagnosing malaria, is it your microscopic smear, serology, rapid malaria test kit, or your gene expert? The answer here is your microscopic smear. So according to your CDC, microscopic examination and trying to identify the morphology of your trophozoites remains the gold standard for laboratory confirmation of malaria. So these tests should be performed immediately when ordered by a healthcare provider. All right. The current 2023 life expectancy for Filipinos is 70 years, 71 years, 80, or 81 years. So sometimes these questions do come up in the board, so you need to know in 2023, the average expectancy is 71 years. So this is from the United Nations data. If there's a 0.18% increase from 2022, we are now at 71.66 years life expectancy. Okay. Last question for your midterm exam. Your annual gross income as a moonlighting physician is exactly 200,000 pesos. According to the revised 2023 tax schedule under RA 10963, the tax you have to pay is 0%. This is non-taxable. 15%, 22,500 pesos, or will it depend on your BIR RIDO? The answer here is 0%. So bakit 0%? Let's go through the train law or the revised tax schedule. Depending on the range of your annual taxable income, the tax will also vary depending on that. So as long as it's less than 250,000 pesos, you are completely exempt from personal income tax. So yung question kanina, what about the 15%? You would only be charged 15% if you are earning over 250,000 but not over 400,000. Now note, you will be taxed 15% of the excess over 250,000. What does that mean? Even if you're earning 400,000, for example, yung 250,000 that you started with, that will still not be taxed. What will be taxed 15% is whatever is in excess of 250,000. So if you're earning 400, may excess ka of 150,000, yung 150,000 na yun ang itatax ng 15% of the excess. And that carries on as you increase your income bracket. So over 400K but not over 800K, you would pay a base tax of 22,500. And then anything over 400K, you would pay 20% off. So the percentage of the tax you pay increases as together with your annual income. Okay, and that is the end of our midterm exam discussions. I hope that you are still alive. I hope that you guys are still okay. And I hope that you learned a lot from those exam discussions. Don't be afraid to reach out for any questions or clarifications that you may have. And don't forget that this is a learning tool. This is not just an assessment tool. It is a way for you to learn from your mistakes, to celebrate the answers that you got correctly, and hopefully to build and gain confidence as we get closer and closer to the PLE. So good luck to all our top-notch students. I really wish you guys all the best, and I'm sure that I will see you at the end of the finish line as my future colleagues. All right, so best of luck to my future doctors. Bye.